Thank you and welcome, everyone. It seems that every time we turn on the news these days, we witness a new traumatic event. Whether this be a natural disaster such as the earthquakes that happened in Turkey, Syria, Morocco, and more recently in Afghanistan, or wars around the world like what's happening in Ukraine. It's important to remember when having these conversations and discussing these traumas, the psychological impact of trauma on those who experience it and those who witness it. So far, we've spoken quite a bit about PTSD as one of these psychological impacts of traumatic events. Something else that it's important to mention that was mentioned earlier on is that PTSD rarely happens in isolation, and in almost 80% of cases, there is a comorbid disorder. And in 50% of those cases, it is major depressive disorder. So in this final presentation of this session, I'm going to shift the focus a little bit to mood disorders, specifically a neuromodulatory treatment referred to as repetitive transcranial magnetic stimulation, or RTMS. So just a quick outline of what I'll talk about today. So first I'll introduce RTMS as a treatment and a little bit about its history, and then we'll talk about it as a treatment for treatment non-responsive cases of depression, and then we'll shift a little bit to some vulnerable populations and RTMS as a treatment for these populations. And then finally, I'll discuss some barriers to accessing treatment. So what is repetitive transcranial magnetic stimulation, or RTMS? So RTMS is actually, the physics of it is based on Michael Faraday's law of electromagnetic induction. And essentially what this law states is that a primary current, or creating a primary current, can then produce a magnetic field. And this magnetic field can then go on to induce a secondary current. And this law was what inspired Dr. Anthony Berker and his team in 1985 to create the first RTMS device, which is shown in this image here. Since 1985, much research has taken place advancing RTMS until it's received approvals in both by the Health Canada approval in 2002, as well as US Food and Drug Administration approval, or FDA approval, in 2008. And it's been approved as a treatment for treatment non-responsive cases of depression, which was defined as not responding to an adequate dosage for the adequate time period of one treatment, and then receiving RTMS afterwards. So what does a modern-day RTMS machine look like? So if you take a look here, this is an image of a modern-day RTMS machine, and essentially the patient would sit back in this reclining seat, and there's this figure-8 coil that's placed just above their head, which produces that primary current. And as you can tell, RTMS is a completely non-invasive treatment, and a typical treatment session lasts from 20 to 40 minutes, and it's provided 5 days a week for approximately 4 to 6 weeks. Some contraindications of this treatment include the patient having any implants, whether that be neural implants, a cochlear implant, or even a pacemaker, or a history of previous neurosurgery. Another contraindication is a history of seizures, major head trauma, or traumatic brain injury. So what about the adverse effects or potential side effects of this treatment? This treatment has very minimal side effects that are very mild and transient in nature. The most common side effects are mild headaches and some facial stimulation that tend not to last beyond an hour after receiving a treatment. The most severe potential side effect that's also very rare is a risk of seizures being induced. But this only happens in about 1 in every 30,000 participant. And to further mitigate this risk, that's why we have history of seizures as a contraindication of this treatment. So finally, what about effectiveness? So there is a 2022 scoping review that looked at any literature that looked at RTMS as a primary treatment for treatment non-responsive cases of depression over the past 5 years. And what they had found is, out of the 17 studies they included, about 16 of them had concluded that RTMS does show promise as both a safe and effective treatment, with remission rates ranging from 29 to 43% and response rate up to 69%. So what about RTMS within more vulnerable populations? So in post-traumatic stress disorder, there's been 2 systematic reviews recently that looked at it as a treatment for PTSD. And there was a cumulative of 29 unique papers across these 22 studies, and what they found was that RTMS does show a promise to be more effective than sham treatment or inactive form of RTMS as a treatment for PTSD and comorbid depression. However, it's important to also note that due to the limited samples or the limited amount of studies and the small sample sizes and the high heterogeneity amongst the studies, there is definitely a need for more studies on this topic. So for the remainder of the presentation, I'm going to shift our focus to peripartum depression. So what is peripartum depression? Peripartum depression is depression with symptom onset during pregnancy or within about 4 to 6 weeks after delivery. And it has about a 15% prevalence rate in new or pregnant mothers. And PPD, or peripartum depression, is also a leading cause of maternal death to suicide or overdose. And the impact of depression, specifically in this population, isn't only limited to the mother, but will also impact her ability to care for her child's psychological and emotional needs, which can result in some developmental issues in the child as well. And for all of these reasons, and many, many more, it is very crucial to offer timely and effective treatments to this population. Currently, typical treatments include psychotherapy, pharmacotherapy, as well as electric convulsive therapy. But there is certainly a need for more and different treatments for this population as well. And for this reason, we completed a systematic review to look at the effectiveness of RTMS as a treatment for this population. And we were also interested in the safety of this treatment for this population as well. So back in December 13, 2021, we completed a systematic search within 7 databases, and after our screening process, we were able to include 7 articles. 4 of the articles looked at RTMS as a treatment during the postpartum period, and 3 looked at it during pregnancy. So for a study to be included, RTMS had to be the primary treatment, and the participants needed to be diagnosed with peripartum depression as defined by either the DSM or ICD. And all the studies needed to be randomized or non-randomized peer-reviewed studies. So what did we find in terms of efficacy? So from the 7 studies, 2 of them were randomized control trials. The first looked at RTMS during the postpartum period and noted that in the active RTMS group, there was about a 39% response rate to the treatment. And within the sham or inactive form of RTMS, there was about a 6% response rate. Looking at the pregnancy study, the active group noted about an 82% response rate and a 27% remission rate, and which can be compared to the sham group that noted about a 45% response rate and an 18% remission rate. Although this does point towards RTMS being effective within this population, it's also important to note that these differences didn't make it to statistical significance. The other 5 studies were open-label trials, and the ones looking at RTMS in the postpartum period noted a 67 to 89% remission rate, and in the pregnancy group, they noted a 41 to 70% response rate and a 21 to 30% remission rate. So what about safety? So again, we noticed quite a majority of participants didn't experience any side effects, and those who did, they were very minimal. And again, in the postpartum studies, the more common, or the side effects they observed were minor scalp discomfort, mild headaches, treatment site pain, as well as facial stimulation. In the pregnancy studies, they also noted mild headaches as well as facial stimulation, and they additionally saw some eye twitching, dizziness and nausea, supine hypotension, jaw pain, and preterm birth. However, what's important to note is this was observed in only one of the studies, and out of the 26 participants of that study, 3 had preterm birth. However, due to the small sample size and the study was underpowered, and they were unable to accurately conclude if RTMS was the cause of the preterm birth or if it was due to another reason altogether. But they did note that 2 out of the 3 participants had a medical condition or a history that predisposed them to preterm birth. So what did we conclude? RTMS does appear to be an effective and safe treatment with limited and tolerable side effects and a low dropout rate. But we also have to keep in mind that the existing research on RTMS in this population is limited and underpowered, and there is certainly a need for more randomized control trials with a larger sample size. So as a result of this research, we decided to see some of the barriers people are experiencing to accessing this treatment. And we wanted to see what are the barriers to accessing treatment in general during the postpartum and pregnancy, as well as to RTMS specifically. So what did we do? So we decided to complete surveys, focus groups, as well as interviews. So for the surveys, we created 2 surveys, one directed to people who've experienced depressive symptoms while pregnant or postpartum, and the other to health professionals. Recruitment is still ongoing, but so far we've collected about 949 surveys that were either fully complete or partially complete. For the focus groups, we've had one focus group thus far with about 9 participants, and we've completed approximately 36 interviews. So what did we find from all of these conversations? Again, we're still performing the analysis, but some preliminary results that we observed were that there were 3 major barriers to treatment. The first being education. Many participants reported that a lot of the time they were even unable to identify these depressive symptoms within themselves, or they didn't realize that what they were experiencing wasn't normal for pregnancy. And there was a desire to have learned more about these symptoms even in school, or for their health professionals that they've been exposed to have told them that, you know what, this may not be normal and there are options for you. The second level of that was their ability to receive a diagnosis. Many had said that they've gone to their obstetrician during this time many times, or they've spoken to family doctors who were unable to provide them with a diagnosis or just dismissed them, saying that this is normal for pregnancy and postpartum is just hard and it'll go away later. The final layer to education is an awareness of what treatment options are even available to this population. There is certainly a fear in many people of receiving medications or any other treatments out of fear of how will it impact my child, whether it be their developing fetus or breastfeeding, so they do not receive treatment altogether. Another huge barrier is stigma. Many participants reported feeling afraid to come out and speak about their depression because how will I be viewed by my spouse? How will I be viewed by my family, friends, and my community? And this fear also led to a secondary fear that many people had mentioned, was a fear of if they did speak out or talked about not feeling well, that they may lose their child, or their child may be taken away from them because they would be deemed unfit to take care of them. The final barrier I'm going to discuss today is accessibility, and accessibility also has multiple layers to it. First being mental accessibility. As we know, depression is a very debilitating disorder, and for many people it's difficult to even get up in the morning or do basic tasks. Nonetheless, identify the symptoms within themselves, find the energy to see a doctor, and then follow up with those consistent appointments. Another layer to this is physical accessibility. Many who either lived in rural areas where there's limited access to health services, or they just didn't have access to a vehicle or a way of accessing these treatments, or they just didn't have childcare to allow them to receive treatment. And the final part of that is the COVID-19 pandemic. As a result of this pandemic, many participants had felt very isolated, and also there was this residual fear of going to health professionals even once restrictions were drawn back a little bit. So what is the importance of this research? So first and foremost, the only way that we can start to address these problems is by identifying that we have a problem. And the best way to do this is to really engage with our communities and understand the problem from their perspective. And I think that's what we're starting to do here by identifying some of those barriers and facilitators to treatment. Then, equipped with this knowledge, we can then go on to create some initiatives or inform policies that will begin to address these barriers and see change. And hopefully by doing this and having these initiatives and new policies, we can increase the chances of someone receiving treatment and actually improving their symptoms and their quality of life. And the more patients that we have that are treated and feeling better, this will also trickle down to improved child development and attachment styles. So what are some of the take-home messages of this presentation? First of all, it's important to note that yes, depression is a debilitating disorder, but it is treatable. And one of the ways to treat this could be RTMS, as it shows promise as a safe and effective treatment. And also from our research, we've identified 3 main factors that may be impacting access to treatment, which are education, stigma, and accessibility. So hopefully, as this research continues to progress and more policies and initiatives are made, we can begin to realize a world where we bridge that gap between a patient's need for treatment and their ability to actually receive it. Thank you.